Assalamu alaikum. My name is Kiran Amir, and I'm the Director of Operations at Parsa Echo Pakistan Super Hub. I would like to welcome you all to yet another Echo session in series of digestive disease Echo. It's in collaboration with Gets Pharma, and we are thankful for the unrestricted educational grant. Today's session is titled Acid-Related UGI Disorder Treatment Options, Pros and Cons. And our expert for today's session is Professor Badr Fayaz Zuberi. Before I introduce you to our expert for today's session, we have to go through some standard announcements. We are part of a global movement called Project Echo based in USA with an objective to disseminate knowledge and best practices. We do protect patient privacy, so none of the information used in this session will identify any individual or patient. For maintaining discipline, you all are muted, but we do encourage participation, so you can unmute yourself for questions or use the raised hand option or chat box. By participating, you have given the consent for recording. The recorded session will be available on our YouTube channel and link will be shared in the chat box. For CME credits, please contact Uzair, our coordinator. His number is mentioned on the banner. CME credits are affiliated with Jinnah Sindh Medical University. Uzair will share the Google form at the end of the session, which will be active for 12 hours. You are requested to fill it as soon as possible to avail the opportunity of CMEs. For the convenience of spokes, the session is bilingual. Please speak in Urdu, English, whatever language you are comfortable in. If you are interested in Parsa Echo's publications, please fill the form shared in the chat box. Our expert today is Professor Badr Fayaz Zuberi, worked as Professor, Dean, Medicine and Allied Sciences at Dow Medical College, Dow University of Health Sciences, Karachi, and consultant physician and gastroenterologist based in Karachi. Before his appointment as Dean, he served as Chairman, Department of Medicine at DUHS. He is CPSP approved supervisors for medicine and gastroenterology training, leading to FCPS gastroenterology. He has thrice received Young Investigator Award on his research papers and have more than 90 publications in local and international journals to his credit. It's an honor for us on Echo platform that he has joined us today. So without further delay, I will hand over to him. Ji, Professor Saab.
Okay, thank you, Kiran and Asad, for inviting me to have this talk with you. I'll be sharing my screen now. So let's start with the presentation. Sorry for the technical glitches. So today I'll be talking about acid-related upper GI disorders, the different treatment options with their pros and cons, their advantages and disadvantages, etc. Next slide, please. Uzair, you have to change the slide. Yes, I have nothing to disclose. Next slide. These are the topics which I will be dealing with. Number one, peptic ulcer disease, along with the role of Helicobacter pylori, GERD, and dyspepsia. Next slide. Now, what is peptic ulcer disease? First, its definition, it is a break in the inner lining of the stomach, the first part of small intestine, or sometimes lower esophageal lesions is also included in peptic ulcer disease. And ulcer, which is present within the area of the stomach, is called the gastric ulcer, while the one in the first part of the intestine, that is the duodenum, is called a duodenal ulcer. Most of the symptoms are the same, but with slight difference in their timings. The most common symptoms of duodenal ulcer are waking up at night with abdominal pain and abdominal distress that improves slightly with eating, while the other is the true when the patient feels pain more while eating. So gastric ulcer pain increases with eating, while duodenal, it is slightly improved on the eating. The first history of perforated peptic ulcer has been described in Princess of Harigita of England in 1670 year. So it's quite a long history, and it's present seen since a very long time. Next slide. Next slide. And there along with the other etiologies, the foremost myth about the diet is that the diet does not play an important role in either causing or prevention of ulcers, peptic ulcers. So this myth was firstly, for the first time, proved by Marshall and the Warren, the two scientists from Australia, with proof that it has some, along with the other etiologies, a very important etiology of causing of peptic ulcer is Helicobacter pylori. They proved this in 1982, and they received a Nobel for that in 2005. In fact, Mr. Marshall drank the petri dish of infected Helicobacter pylori, and then he developed severe gastritis, and thus proved that this is one of the reasons for peptic ulcer disease. The treatment for this ulcer disease includes stopping the smoking, stopping the use of NSAID, stopping alcohol, and taking medication to decrease the stomach acid. The main crux of the treatment is to effectively decrease the acid and raise the pH of the stomach beyond 3.5. Next slide, please. Next. Now, with the peptic ulcer disease since long, when the treatment was not so efficient, there were a lot of complications, lot of perforations. People used to die a lot of peptic ulcer. Lot of surgeries were performed on peptic ulcer disease at that time, in that era, before the era of H2 receptors were found. And one of these complications was the stricture forming in the stomach, leading to an hourglass stomach. You can see that in this, you have a stricture giving an image of an hourglass in the stomach. Among the other problems, one of these was the hourglass stomach. Next slide. And then there were certain surgical interventions because there were no medication available. So surgical interventions was used to be done for these peptic ulcer disease, healing of peptic ulcer disease. These included vagotomies. Then initially it was a truncal vagotomy which occurred at the top level of the trunk of the vagus, which along with the decrease, caused the decrease in acid production, also resulted in other disorders, which resulted in improper digestion, bloating, and other complications of this type. Then came in the era of selective vagotomies, in which some branches, major branches of the vagus nerve were cut while preserving the hepatic branches and the branches to the pylorus, which were done in the highly selective vagotomies. Thus, in this highly selective, the parietal cell bodies, the nerves to parietal cell bodies were ligated, and the nerves to the antrum were preserved. So some motility disorders could be overcome while doing these vagotomies. And again, the vagotomies itself carried a lot of complications also and a risk to the patient at that time. So you can imagine how difficult it was to treat an ulcer disease, which was so common. Now that we don't think even of it, it's a major cause of disorders and leading to such disorder. You rarely find a bleeding peptic ulcer now. You rarely find a peptic ulcer which has perforated now. Not so common, although they do see, but not so common. Next slide, please. Now you see, with initially when the treatment of peptic ulcer came, the first things that had to come was the antacids, and which used to give an immediate relief to symptoms, but the relief was very short time. Healing rate was not very significant. And with the antacid, they were to be taken very frequently, and they lead to overload of calcium, magnesium, and alkalis, causing other symptoms of the patient with these antacid. And definitely the healing was not so good at that time. Then came H2 receptor antagonist. And you see, when the H2 receptor, the first to come was cimetidine. And it became a wonder drug at that time when it was introduced, cimetidine. It was much better. The patients started getting relief at a very faster pace. And it was taken as a miraculous drug at that time. But there was still some problems with that. And that included some cytochrome P450 interactions. But the major problem was very frequent relapse. When you stop taking the drug, the symptoms used to reoccur within a few period of time. Then again, a major breakthrough came with the introduction of proton pump inhibitors. The omeprazole was the prototype at that time. It was discovered or released in later part of 80s or in the beginning of 90s. And it was when it was the acting on the end receptor and was giving a very good suppression, better than the H2 receptors with quick symptom relief, and the duration of action was prolonged. It used to raise the pH beyond 3.5 or 4 for most of the time of day for 12 hours or more. And then there were, you see, other sister drugs of omeprazole came in with some advantages on that. But still, the relapse rate was high. And with the incumbent problems with the PPIs, all of the PPIs, that it has to be taken 30 to 40 minutes before breakfast or major meal. And then the duration and the presence of acid also cause deterioration of this action. Thus, you see, the relapse was there. And then better in the different forms of PPIs came in which there was lansoprazole, pantoprazole, and then these all were marginally better. Some in a duration of action, some in the drug-drug interaction. So, but the efficacy of increasing the pH beyond 4 was nearly the same, which is the basic requirement of healing and ulcer in a peptic ulcer disease. So for 2 decades, we were using the PPIs, but nothing happened in the relapse and no major change came in the drugs availability. Then there was experimentation with the PPIs. Some of the PPIs were made in combination with some bicarbonates for immediate relief. Some were combined in a delayed action formulation. And then one of the very best that performed at that time was the dexlansoprazole, which has a dual action with some of the salt was rapidly released and some later on to give a longer duration of action. So the pH may remain elevated for longer period of time for better healing of the ulcers. Now, recently, the PCAPs have emerged, have been launched, which are much better even on PPIs. They have a longer duration of action. Their action may remain for more than 18 hours. So they require truly once a day treatment. And their type, they do not have any interaction with the food, so they can be taken before food or after food. So these advantages have become very good in these with this point of view. Now I will come towards next slide, please. We do not have yet much data on relapse rate of PCAPs, which will come up as these are new drugs. The data will come up and we will have some views on it. Next slide, please, Umer. Uzair, sorry.
Sir, wait a moment, it's not working.
Okay. So with this, even with the advent of PPIs and other drugs, the notion that once an ulcer and always an ulcer, कि जिसको अल्सर हो गया वो सारी उम्र अल्सर ही भुगतेगा या उससे सफर करेगा.
Zach, can you आप दोबारा शेयर कर सकते हैं स्लाइड्स?
Can you see the slide?
Yes, I can see the
जी
slide.
जी उजैर, we can see the slide. आप इसको बेशक ऐसे ही रखें, वो स्लाइड शो में ना लेके
फुल
जाएं.
स्क्रीन पे प्रॉब्लम कर रही है. हाँ.
आप हाँ जी फुल स्क्रीन पे कर दें इसको, ठीक है.
Now you see that notion, when it was proved that Helicobacter pylori is one of the causative agent, not only that other things, that is the mucosal damage and other theories of that peptic ulcer generation, but Helicobacter had a strain. Now, strangely, the Helicobacter is a very strange organism, resides under the mucus gel layer of the stomach, destroys the joint tight junctions of the epithelium, present has a high prevalence rate of around 70% in developing countries. And it is said that overcrowding, living in a substandard settings, not having good access to clean, palatable water are most of the causes of this development. And people acquire this infection. It is shown that in a very early age, before the age of 10 years, most of the people acquired it, those who have acquired it. So when you see that 70% of people in a developing country, that's a huge chunk that we are talking about and the people are having. Again, the treatment is challenging. It requires maximum acid suppression throughout day and night with very high doses of antibiotics, for which the resistance is low in that community. Now, there's a problem. We do not have much of the figures of resistance in our antibiotics. In the bigger cities, it has now, for the last 4-5 years, we are having the data of antibiotic resistance from every hospital, major hospitals. So now we have, and we know what's the resistance rate is going on. Basically, the antibiotics required in Helicobacter pylori are clarithromycin, amoxicillin, and metronidazole, 3 major forms in the first line of therapy. And these are the so common antibiotics which are used all over the Pakistan for many indications. And then there's a problem when any of these antibiotic has been used. Within the previous 2 weeks, you cannot give it. So you have to wait for 2 weeks to pass so you can give this antibiotic for H. pylori treatment. Otherwise, the chances of cure are less. So with this incumbent problem with the Helicobacter pylori eradication, I will discuss the major currently available regimens, currently recommended regimens of peptic ulcer disease in association with Helicobacter pylori eradication. So next slide, please. So Helicobacter pylori treatment requires twice daily dosing of PPI. So the pH of the stomach remains elevated throughout the day. So whatever the standard dosage is, that is for omeprazole, it is 20 milligram. For pantoprazole, it is 40 milligram. For lansoprazole, it is 30 milligram. So whichever the salt you are using, it has to be given the standard dose, but in twice daily doses, 12-hourly doses. And then twice daily dosing of either clarithromycin or metronidazole, 500 mg. But in Karachi, the resistance to both these drugs is been reported for more than 30%. So any drug which is having a resistance of more than 15% should not be used for the treatment of eradication of Helicobacter pylori. And then along with any of one of these antibiotics from the two selection, if you see whatever, whichever have a lower resistance, you prescribe, choose that one. And then twice daily dosage of amoxicillin. Now, amoxicillin is a mainstay. It will be there because luckily, the resistance to amoxicillin has been reported very low in Pakistan. But the dose required is 1000 milligram twice daily. So remember that low dosage won't work. So it will decrease the efficacy and the chances of cure. So 1000 milligram, or you can say 1 gram of amoxicillin twice a day. And all these medications must be taken for 2 weeks. There should be no interruptions. You should counsel your patient that this is a take it or leave it phenomena. Whenever you are ready, you take it for continuously 2 weeks. And if you are not ready, it's better to defer the treatment for Helicobacter pylori for a few weeks before you become sound and stable. So you can take these medication for continuously for 2 weeks without interruption, without missing the dose, without decreasing any of the dosage. That's most important part of Helicobacter pylori treatment is the counseling. And remember, 70% of population is present, but 70% of population, the symptoms are not so much. Helicobacter pylori, we are treating not for the symptoms, but because it has a 10% risk of developing peptic ulcer out of the 70% of the population that is having. The risk of ulcer is around 10%, and risk of malignancy is less than 3%. So when we are treating, we have to tell the patient that there may not be an improvement in symptomatology if there is not an ulcer and it's just H. pylori, and if you are treating Helicobacter pylori, the chances of symptomatic relief may not be there, even after eradication. Next slide. Now, with the advent of PCAPs, we have come up with a better treatment regimens and a better response rate. The two regimens that has come up, one is with clarithromycin, which has been approved, and one is without clarithromycin. So in both these cases, the PCAP is to be given in a twice daily form. So that dose will remain twice a daily. Option one, in which you give clarithromycin, if in your area the clarithromycin resistance is low, you can use this option, in which the clarithromycin will be 500 milligram twice daily with amoxicillin 1000 milligram twice daily. But if the clarithromycin resistance in your area is high, it's better to use amoxicillin 1 gram thrice daily. There are some reports coming up in which in the first option, Amoxicillin 500 milligram twice daily is being tried, along with twice daily PCAP and 500 milligram clarithromycin twice daily, and it's also showing good results. But both these options, the treatment will last for 2 weeks with the same advice that it should not be interrupted, taken continuously without change in any dosage of these drugs. And with this, we expect a result of 95 to 98% eradication of Helicobacter pylori with these medications. Next slide. Now, I will say a few words on GERD, which is a gastroesophageal reflux disorder or disease. And it is defined as the symptoms. It is also one of the form of acid peptic disorders. And it should be defined as symptoms or complications resulting from the reflux of gastric content into the esophagus or beyond into the oral cavities, including the larynx or the lung. So it's not only just a GI disease, it's an oral disease, it's a ENT disease, it's a pulmonary disease, and it's a dental disease also now. So reflux gastric contents, you all know that the only part in our body which has a pH, acidic pH is stomach. Whole of the rest of the body is alkaline. So when this acid comes into the other surroundings, even a single drop will cause a lot of symptoms, and that's what the etiology of GERD is. You find a lot of heartburn, symptoms, burning that comes up when the reflux starts setting in. For diagnosis, a presumptive diagnosis can be established in the setting of typical symptoms of heartburn and regurgitation occurring after food, on lying down, and empirical medical therapy with a PPI is recommended in these settings. Patients with non-cardiac chest pain suspected due to GERD should have a diagnostic evaluation before institution of GERD therapy. A cardiac cause should be excluded if there is a patient, you have a slightest doubt that this pain and the symptoms of the patient may be due to cardiac. It's always recommended that you take a cardiac opinion and rule out cardiac causes for that pain before going on or labeling the patient as that of a GERD or acid peptic disorders. The role of barium in diagnosing GERD is obsolete now. And for diagnosing GERD, Mr. Barium is considered to be dead now. Next slide. Although there are still some indications in other areas of GI, but for diagnosing GERD, barium is not recommended anymore. I think you skipped one slide, so it's okay. Okay. So
that slide number 13, is it there?
या इसको ओपन कर दें, किसी ने इसको हाइड हो गया है गलती से, इसको ओपन कर दें प्लीज, इसको हाँ हाँ ये कर दें. Yes, very good. So you see, for diagnostic testing, a PPI trial is indicated in the classic symptoms of GERD if there are no warning signs. The warning signs include weight loss, anemia, melena, etc. So if there are no warning signs and the patient is giving a very classical symptom of retrosternal chest burning after food or on lying down, then it is advised that we can give a PPI trial for 2 to 4 weeks. But again, a negative trial does not rule out GERD. Sometimes the symptoms may persist and patient may have a very severe disorder of the GERD. So the PPI may take longer to act. So one caution needs to be observed. Barium swallow, as I said, that it's no longer recommended for use of evaluation of for GERD, but for evaluation for dysphagia, you can do it. So I said for evaluation of GERD, barium has no role, but for evaluation of dysphagia, for strictures, for eclasia, or for pregnancies, you can still use barium swallow. So it is not used unless you have a suspicion of a completion like a stricture, ring, or malignancy in your mind for barium swallow. But still, you will be needing a biopsy for all those disorders. So an endoscopy will have a precedence over the barium swallow in such cases. Endoscopy, if there are alarm symptoms, screening of high-risk patient with more age in which the symptoms arising at the age of more than 55 years, then there is an indication of doing an endoscopy. And if you are suspecting those at the risk of Barrett's esophagus, you can, or those who have not responded to your initial trial of PPI, then we can consider doing endoscopy in such patients. Sometimes we do biopsy, esophageal biopsy, to exclude non-gut causes of symptoms, but definitely it has no role in diagnosing the gut. Esophageal manometry is also not indicated for diagnosing of gut, but if you are planning to recommend the patient for a surgery, then a pre-surgery evaluation is required. For that, you can do esophageal manometry, or if you are considering other disorders or to rule out other disorders like eclasia, scleroderma, etc., then you can do a esophageal manometry, so you can plan better your surgical intervention in such cases. The role of reflux ambulatory monitoring for non-invasive refractory gut symptoms and can be done, but it has to be correlated with reflux documentation of abnormal acid exposure or reflux frequency. This can be documented in, but the last two investigations, especially the ambulatory reflux, is done when the patient is not responding and you are not finding anything significant on endoscopic findings also. Next slide, please. So when we come to the management, weight loss is recommended for gut who are overweight or who had a recent weight gain. In both these patients, it is highly recommended that the weight loss to be done. At least 10% of initial weight should be lost over the next 3 months so that the gut symptoms may need a better way. The other things that include in the lifestyle are the elevation of head end, avoidance of meal 3 hours before bedtime, and not offering prayers. Musliman prayers पढ़ते हैं, so you offer prayers first before you take your major meal. So पहले खुदा फिर पेट पूजा, ठीक है? So you have to take a meal, because during rakus and sajud, the body becomes upside down and the stomach becomes upside down and the chances of reflux increases. Now, global elimination of food that trigger reflux, including chocolate, caffeine, alcohol, or spicy food, it has shown to be not a major cause for this reflux, and their elimination is no longer recommended at this point of time now. So a better drug to reduce the acid content is the mainstay in the treatment. An 8-week course of PPI or PCAP, nowadays they have become the first line of therapies. Choice of relief of symptoms of erosive esophagitis also. And if there are no major differences in efficacy in different types of PPIs and that of PCAP in this condition. Although the PCAP have a longer duration of action, can be taken once a day, and the PPIs with prolonged combination delayed action are also being used in this day. Remember that in the management of the gut, we are talking about tailoring to the patient need. And this tailoring may come in various forms. We may start with a step-down approach in which we can start with the higher doses of PPIs twice daily, and then tapering them down as the patient feels relief to once a day, and then bringing down to maintenance dosage of half dosage, that is 10 milligram of omeprazole and so on, to the maintenance therapy of these patients. In some of the patients who have very severe reflux, you can think and consider adding an H2 receptors at the night time, at the bedtime, along with the omeprazole or PPI or PCAP, so that to nighttime, the basal acid secretion, which is better inhibited by H2 receptors as compared to PPIs. Next slide, please. So the maintenance therapy should be administered for GERD who continue to have symptoms after PPI is discontinued. And in this patient, complications including erosive esophagitis or Barrett's is present, that should be all taken to that and managed according to their specific protocols. For patients who may require long-term PPI therapy, the PPI should be administered at lowest effective dose, including on-demand or intermittent therapy. Now, there is this, what is this intermittent therapy or on-demand therapy? The on-demand therapy is that we advise the patient to have a 3-day course of omeprazole or PPI kept at the home, and he can start with this whenever the symptom reoccur after it has been stopped. So within the 3 days, if the symptoms do not relieve, he should consult back to you with the doctor, with the consultant, or whatever, whoever is managing that patient. This is called on-demand intermittent therapy. The H2 receptor antagonist therapy can be used as a maintenance option in patient without erosive disease if the patient experiences heartburn relief with these symptoms. And again, as I said earlier, that H2 receptor therapy can be added to a daytime PPI therapy in selected group of patients with objective that the nighttime reflux, if needed, is better controlled with the H2 receptor, as the basal acid suppression rate is suppressed much better with the H2 receptor antagonist. Next slide. Now we come towards a third acid-related disorder, common disorder, that is dyspepsia. Now, there's not much consensus about the definition of dyspepsia, and it presents very differently. So very different and very definition of this brand. So it can be summarized as a complex of symptoms referable to the upper GI, gastroduodenal region of GI tract, that includes epigastric pain, burning, post-pharyngeal fullness, or early styted, etc. So you see there is a huge difference in the presentation that are included under the term of dyspepsia. Now, it has been seen that 80% of people who present with dyspepsia have no structural explanation or underlying disease of the symptoms, and they are also labeled as functional dyspepsia. And it is very prevalent. Functional dyspepsia affects up to 16% of otherwise healthy individuals in the general population. So it is a very common disorder in the general population, dyspepsia, and every general physician and gastroenterologist is bound to have a lot of patients presenting to him or her with these symptoms, which can be grouped under the heading of dyspepsia. Next slide. Now, what are the risk factors for developing dyspepsia or would contribute to dyspepsia? The risk factors, they include the psychological comorbidity, acute gastroenteritis, female sex, smoking, use of NSAIDs, and Helicobacter pylori infection. So Helicobacter pylori does have some role in dyspepsia also. Its pathophysiology remains incompletely understood. but it is probably related to disordered communication between the gut and the brain, that is gut-brain axis, leading to motility disturbance. Again, the visceral hypersensitivity and alterations in gastrointestinal microbiota, mucosal and immune functions, and CNS processing of information originating from the GI tract. So you see whole varied causes of explanation for dyspepsia, for the varied presentations of dyspepsia or causes or risks of dyspepsia. You see, starting from the acidity to infection of Helicobacter pylori, from the brain-gut axis, visceral hypersensitivity, and normal gastrointestinal flora. So all are contributing to dyspepsia, and it's a very difficult task for a treating physician to pinpoint this and to treat them accurately. Next slide. You see, with dyspepsia or functional dyspepsia, one need to have a normal upper GI endoscopy to tell them that you are having a dyspepsia or a functional dyspepsia, and there's nothing wrong in your gastrointestinal mucosa or in the upper GI tract on this patient. But its use is minimal, but it should be done when the symptoms arise in the late period of the age, that is, if the person is first time reporting with dyspepsia over the age of 55, and those with concerning features like weight loss, vomiting, etc., then endoscopy should be done in such patients in which the dyspepsia is present. But due to our incomplete understanding of pathophysiology, functional dyspepsia is still very difficult to treat in most of the patients, and condition remains chronic, and the natural history is of fluctuating symptoms. So these patients may be wandering from one doctor to another doctor with having the same drugs with different brands changing, and maybe some of this will click and they will have a beneficial effect on that. Next slide. Now, while treating this dyspepsia, one should check for Helicobacter pylori infection, either via hydrogen blood test or with a stool test, antigen test, not by antibody blood test, which is obsolete. And if this patient is found to be patient with dyspepsia found to be infected, one should offer the treatment of H. pylori, again telling the patient that there's a chance that the symptoms may not improve, but we are treating Helicobacter pylori for the reasons that it is a class A carcinogen and it can cause ulcer. So it should be treated. I've seen a lot of people who test for H. pylori and tell to the patient that they have an ulcer. वो कहते हैं कि हमने ब्लड का टेस्ट कराया, हमने स्टूल का टेस्ट कराया, उसमें अल्सर आया. So please tell them that this is an infection, this is not an ulcer. H. pylori treatment or H. pylori test positive does not mean that the person is having an ulcer. It is only documents that the person is having an active Helicobacter pylori infection. So other therapies with the evidence of effectiveness, including proton pump inhibitor, CCAP, PCAPs, histamine H2 receptor antagonist. And this is one of the area where prokinetics or digestive enzyme supplements do works in some group of the patient, a selected group of patient, and some central neuro modulators may be given in these patients, like which can help in a selected class of patient, not all of them. Again, the psychological therapies have been prescribed and been given into such patients, but their role and effectiveness is still uncertain. Some of the patients do get benefit from these psychological therapies also. So with this, I conclude my presentation, and the next slide will be thanking you for your attendance and listening to me patiently. And hope you have benefited from my talk. Thank you so much. Goodbye.
Thank you. Thank you very much, Dr. Badr. It's a very nice presentation और आपने बहुत लंबी चीजों को कवर किया है, बड़ा एक वाइड ओपन टॉपिक था। ये मैं अल्ताफ आलम साहब से कहूंगा कि मैंने आपको यूजुअली वही डिसाइड कर रहे होते हैं, but anyway, it was a wonderful talk. We are now open for question. मैं आपसे थोड़ा जानना चाहूंगा, आपने हेलिकोबैक्टर की बात की और हमने एमॉक्सिसिलिन की बात की इन प्रॉपर डोजेज जो आपने पॉइंट आउट भी किया, और इसके साथ क्लैरिथ्रोमाइसिन और मेट्रोनाइडाजोल। तो व्हाट अबाउट लीवोफ्लॉक्सासिन का एक्सपीरियंस कैसा है आपका विद दिस इन पाकिस्तान, या कोई रेजिस्टेंस आपने देखा इसके बारे में?
हमारी प्रैक्टिस में हमने प्री कोविड एरिया में लीवोफ्लॉक्सिन यूज की, लेकिन उसके बाद से लीवोफ्लॉक्सिन का जो रेजिस्टेंस है वो काफी ज्यादा रिपोर्ट होना शुरू हो गया। तो आफ्टर कोविड आई एम अ बिट रिलक्टेंट। तो अभी इस साल का हमारा डेटा नहीं आया है एंटीबायोटिक रेजिस्टेंस का हमारे हॉस्पिटल से, तो आएगा तो फिर उस पर देख लेंगे क्या है। लेकिन कोविड के बाद से मेरा एक्सपीरियंस जो है लीवोफ्लॉक्सिन के साथ इतना अच्छा नहीं जा रहा।
This will be very interesting. Any question? कोई chat में question है? Just let me check. और एक और चीज जो हम बड़ा कॉमनली फेस करते हैं, that is long term use of PPI. और क्योंकि मेरे ख्याल में PPI को अगर मैं कहूँ कि it's one of the most used and abused drug in Pakistan, maybe all over the world, आप बेहतर रोशनी डाल सकते हैं। तो उसमें आप, क्योंकि लोग तो ले रहे होते हैं, ये बड़ा चैलेंज है। तो आपका क्या एडवाइस होती है? आपका इतना एक्सपीरियंस है विद PPI यूज, आप कैसे गाइड करते हैं पेशेंट्स को?
देखिए, पहले तो पेशेंट को ये समझाना होता है कि ये दवा है, कोई ऐसी गोली नहीं है जो आपने जब मर्जी खा ली, ठीक है ना। तो थोड़ा एजुकेशन करना पड़ता है, थोड़ा टाइम देना पड़ता है। हमारे पास डॉक्टर्स के पास दरअसल टाइम नहीं होता है, ये सबसे बड़ी प्रॉब्लम। और फिर उसके बाद हमको ये देखना होता है कि इस पेशेंट को क्या वाकई नीड है कि नहीं है। तो अगर पेशेंट को नीड है तो उसको कंटिन्यू करें। अगर पेशेंट को नीड नहीं है और उसको कुछ और सिम्टम जैसे डिस्पेप्सिया के अंदर कोई फैमिली काउंसलिंग की या साइकेट्रिक हेल्प की जरूरत है तो वो उसको ऐड की जाए। और H2 रिसेप्टर के ऊपर दोबारा हमें जाने की जरूरत है, और नाइट टाइम H2 रिसेप्टर जो है अब दोबारा हमारी प्रिस्क्रिप्शंस में आ रही है और पेशेंट्स को उनसे रिलीफ मिल रहा है, जिसके अंदर आजकल हमारे पास फेमोटिडीन अवेलेबल है।
जी, फेमोटिडीन अवेलेबल है जी। एक क्वेश्चन है चैट में, अगेन अ वेरी वाइड ओपन क्वेश्चन, लेकिन आपसे ब्रीफली रिस्पांस चाहिए होगा। GI symptoms in diabetes, can you please throw some light on this?
Well, you see, डायबिटीज के अंदर जरूरी नहीं है कि हर चीज प्रॉब्लम हो आए, लेकिन सम ऑफ द पेशेंट इन of diabetes may be due to gastric autonomic neuropathies that may lead to gastroparesis, ठीक है ना। और उसके अंदर along with the, जैसे हम कहते हैं कि ऑटोनॉमिक न्यूरोपैथी और दूसरी इसके साथ पेन रिसेप्टर की प्रॉब्लम, तो यानी डायबिटीज में है ही अगर न्यूरोपैथी सिंड्रोम। लेकिन एक वेरी पिक्यूलर सिम्टम्स जो डायबिटीज के अंदर देखा जा रहा है वो है गैस्ट्रोपेरेसिस का। उसके अंदर स्टमक के अंदर फूड खाली नहीं होता, जो स्टमक एम्प्टिंग टाइम है वो बहुत डिलेड हो जाता है, बहुत लंबा हो जाता है। खाना खा लिया, वो पड़ा हुआ है, आगे नहीं जा रहा, ठीक है ना। तो गैस्ट्रिक एम्प्टिंग उनके अंदर बहुत प्रॉब्लम, फिर उसके रहने से प्रॉब्लम्स क्रिएट हो रही हैं, डिस्पेप्सिया खास तौर पे। ऐसे पेशेंट्स के अंदर गैस्ट्रोकाइनेटिक्स और उसके अंदर रोल ऑफ रिथ्रोमाइसिन और एजिथ्रोमाइसिन भी ट्राई कर लेनी चाहिए, जो कि बाज़ औक़ात फायदा देती है इन सब पेशेंट्स के अंदर।
जी, ये GI सिम्टम्स एंड डायबिटीज पे हमें पूरा सेशन करना पड़ेगा, मे बी मल्टीपल सेशन। इट्स हमने सिर्फ अभी अपर GI की बात की है, इसमें तो बहुत सारी चीजें और आ जाती हैं। ओके, अच्छा, एक मैं सिर्फ फॉर क्लैरिफिकेशन पर्पसेस, हमने हेलिकोबैक्टर के बारे में बहुत बात की, और जहाँ पे भी ऐसे रिलेटेड डिसऑर्डर्स की बात आती है, आप जनरल प्रैक्टिस में कौन से टेस्ट रेकमेंड करते हैं? आप कैसे, क्योंकि हमारे यहाँ तो सबसे ज्यादा तो जो, अगेन आई वुड यूज द वर्ड यूज्ड एंड अब्यूज्ड, वो जो सीरोलॉजिकल टेस्ट है, थोड़ा सा आप इस पे क्लैरिफाई करना चाहेंगे? आपकी मौजूदगी का हम फायदा उठा लें जरा।
देखें असद साहब, आप भी बहुत एक्सपीरियंस आदमी है माशाल्लाह, और हेलिकोबैक्टर का असल में जो स्टूल टेस्ट है या ब्रेथ टेस्ट है, वो यानी कि नॉन एंडोस्कोपिक टेस्ट 3 ही है, एक ब्लड का, एक स्टूल का और एक ब्रेथ का टेस्ट, सांस में जो टेस्ट है। इनमें से जो ब्लड का टेस्ट है बहुत इजीली अवेलेबल और सस्ता है। अब इसके ऊपर आप अगर पेशेंट को ट्रीट करना चाहें तो इस बात का ख्याल कर लें कि इसने पहले कभी एच पाइलोरी की थेरेपी ना ली हो और ये फर्स्ट टाइम उसने टेस्ट कराया। अगर फर्स्ट टाइम टेस्ट कराया है तो मैं उसको इसकी ब्लड की टेस्ट के ऊपर एंटीबायोटिक, और वो कह दे नहीं मैंने ये कभी भी हेलिकोबैक्टर का ट्रीटमेंट नहीं लिया और ये मैंने जिंदगी में पहली दफा टेस्ट कराया है, तो थेरेपी दे देता हूँ। लेकिन फिर उसकी एफिकेसी को देखने के लिए उसको ये बता देता हूँ कि आइंदा ब्लड टेस्ट नहीं कराना, क्योंकि इसके अंदर ये सारी उम्र पॉजिटिव रहेगा या बहुत लंबे अरसे तक पॉजिटिव रहेगा। ये एजुकेट उसको उसी वक्त करना होता है। और आइंदा आप टेस्ट कराएंगे या तो ब्रेथ का कराएंगे या स्टूल का कराएंगे, ठीक है। अच्छा, ब्रेथ का टेस्ट भी इतना वाइडली अवेलेबल नहीं है। अब कुछ रैपिड टेस्ट की मशीनें आई हैं तो कुछ हॉस्पिटल्स ने वो लगा ली हैं, तो वो कुछ अवेलेबल होना शुरू हुआ है, ठीक है ना। लेकिन स्टूल टेस्ट महंगा है, और फिर उसके साथ फिर हमको ये भी एडवाइस करना होता है कि आपकी एंटीबायोटिक की जब थेरेपी खत्म होगी तो उसके तकरीबन 5 से 6 दिन के बाद आपने ये टेस्ट कराना है या 1 हफ्ते के बाद टेस्ट कराना है। और फिर आप ये टेस्ट करा के हमारे को बात है, ब्लड टेस्ट दोबारा नहीं कराना। इसको बहुत स्ट्रेसफुली एजुकेट करना होता है अगर आपने पहली दफा उसको वो एक्सेप्ट कर लिया है, ठीक है ना। वैसे अगर रिकमेंडेशन देखी जाए तो ये एक मॉडिफाइड रिकमेंडेशन ड्यू टू आवर सेटिंग्स, आवर फाइनेंशियल सेटिंग, कि अगर एक पेशेंट ने मगर पहले भी थेरेपी ली है और आप उसके पास देखते हैं उसमें 3 जो है एंटीबॉडी के टेस्ट लगे हुए हैं, फिर उस टेस्ट पर रिलाई करने का कोई वो रीजन नहीं बनता कि उस एंटीबॉडी टेस्ट पे आप रिलाई करें, ठीक है ना। फिर उसके लिए एडवाइस करें कि आप उसको स्टूल का या ब्रेथ का टेस्ट कराएं, या अगर कोई रीजन, कोई इंडिकेशन एंडोस्कोपी की बन रही है तो फिर एंडोस्कोपिक बायोप्सी के ऊपर या CLO करा लें या हिस्टोपैथोलॉजी पे आप जेम्सा स्टेन करा के उसको देख लें। लेकिन अगर खाली एच पाइलोरी के लिए एंडोस्कोपी भी इंडिकेटेड नहीं है, अनलेस एंडोस्कोपी की अपनी कोई इंडिकेशन मौजूद ना हो।
Thank you very much, sir. It's an honor to have you with us. Or it was a wonderful.
An honor was totally mine for to come on this platform and to be with you all people, great people who are doing very great work. And I'm thankful to you and the ECO and the whole of your team for engaging me in this. And I hope I have contributed a little or something into this also.
Inshallah, we will keep you engaged. Inshallah. Kiran, over to you. We can now wind up the session.
Sure. Thank you very much, sir. And I would also like to inform you all that हमारी IBD echo session है जनवरी में. IBD mimics differential diagnosis by Dr. Junaid Mushtaq Cheema on 25th January at 10 PM. और आपसे इसका शेयर कर दिया जाएगा सून बैनर, ताकि आप रजिस्टर करा सकें। इसके अलावा अगर आप लोगों के पास कोई केसेस हैं जो आप चाहते हैं प्रेजेंट हों हमारे अपकमिंग डाइजेस्टिव एको सेशंस में, तो वो हमें ज़रूर बताइए। और इसके अलावा वी आर ग्रेटफुल एंड थैंकफुल विद ऑल द पार्टिसिपेंट, आवर एक्सपर्ट एंड गेट्स फार्मा फॉर द अनरिस्ट्रिक्टेड एजुकेशनल ग्रांट। स्पेशल थैंक्स टू खालिद महमूद साहब and of course our team at Parsa Eco Pakistan. We hope that this collaboration will produce more informative sessions in future for you. So we will sign off for today. Allah Hafiz. Uzair, you can please call off the meeting.
Sure, ma'am. Allah Hafiz.
Allah Hafiz.